ago, there was a cardiology fellow working in an academic environment, academic center somewhere. He was kind of a fitness freak. He ran marathons. And for some reason or another, he wanted to have a screening test to see if he had heart disease, despite the fact he didn't have any risk factors at all and he didn't have any symptoms. So he goes and has this test, and it wasn't something you had to get shots for or anything like that. So he goes and has this test. The test was positive. Kind of surprising because he's a healthy guy, and he's 40 years old, right? So that requires now an invasive test. So he has a cath, a coronary cath, and that's where they stick a needle into you and ultimately squirt dye down into the vessels of your heart so you can see if there's a blockage, okay? So what do you think that showed? It's actually negative. The test was negative, okay? So now we have this healthy cardiologist, marathon runner, everything's great, his test was negative, end of story, right? Not exactly. Turns out that the cath caused an infection in the lining of his heart. That's called endocarditis. I can promise you, you don't want endocarditis. Hard to treat, a lot of complications go with it. So he had to get admitted to the hospital, put on high doses of antibiotics, and despite that, the infection kind of messed up one of his heart valves. Well, the valve failed, so now his heart's not pumping right. So they have to take him to surgery, take out the bad valve, the one he was born with, put a mechanical valve in. So he did pretty good with that. The operation went okay, but then he developed a fungal infection of the valve. And fungal infections are really hard to treat, and particularly if you have some kind of, bioprosthesis thing in there. Any kind of mechanical stuff just does not do well at all with infection. Our 40-year-old cardiology fellow, marathon runner, no symptoms, dies. So I wish it was a story, some storyline from some TV show, but it's not. That actually happened. And there's some things that we can learn from this case that are important. Number one, from a quality standpoint, patient died. It's hard to imagine something worse than that in terms of an outcome. But think again now about the cost component to it. Hospitalization, complication, surgery, complication. Huge dollars. That would have been hundreds of thousands of dollars. Now, looking big picture at this case now, he had a study he didn't need to have. He had an unnecessary study. And it's a great example of what can happen when you get something that's unnecessary. This is what can happen when you get unnecessary care. So I want to ask you a couple questions, 3 questions maybe. How many of y'all in the room have called the doctor because you feel awful and you need an appointment, and they say, well, we'll be happy to see you in 8 weeks? I got a witness, right? Can I get a witness? All right. So how many of you have gone to the doctor for a fairly minor thing, and by the time you get out of the place, you've got 3 prescriptions, a bunch of lab work, and another test ordered? Do I have a witness? All right. How many times have you gone to the doctor, waited for an hour and a half or something, only to be told you've got something minor, go to Walmart and pick something up over the counter? And then when you're driving to the house, you say, what happened there? I'm not satisfied with that experience. Right? Kind of a problem. So why are we talking about this? We're talking about this because our healthcare system is broken, and this problem of unnecessary care really contributes to it. And if I got into the details about it, I would start getting mad and y'all would start getting depressed, so we'll wait to the end of the talk. So I'm a surgeon. Most of my career, I was a general surgeon. And then most recently, I was an academic breast cancer surgeon. People like to say that surgeons are hard to work with. Well, I admit I can be a little bit prickly. My wife would probably testify that. But I mean, look at what we do for a living. I mean, how many people make a living by putting people to sleep, cutting them open, doing some stuff, closing them back up, and sending them home generally better than when they started? That's just not normal people that do that. It's been observed in the hospital that when the elevator door is shutting and the internal medicine doctor wants to put to stop it from shutting, he runs up and puts his hand in. Now, when the door is shutting on another floor and the pathologist sees the door shutting, she runs up and puts her foot in. On the next floor, when the surgeon sees the door shutting, he runs up and puts his head in. So maybe they've got something on that. So there's a lot of ways that physician can overutilize healthcare, where they can do unnecessary stuff. So the first example we'll talk about are that some doctors are just maximalist. They kind of come into the world almost like that. They learn what they do in residency. They're very risk averse and they don't want to miss anything. But these are the doctors that order a bunch of lab work. They tend to see you in the office more frequently. They tend to order more tests on you. They tend to refer you to specialists more often. They tend to admit you to the hospital more often. They tend to send you to the emergency department on the weekend more often. And it's easy to stand up here and say, oh, you guys aren't practicing right, but the problem with it is we really have a hard time in healthcare knowing exactly what to do. You would be really surprised how little we know about a lot of things. There's thousands of trials that come out every year. There's thousands of papers that come out every year. And you can't keep up. It physically is impossible to do that. You can't read them all. And then it takes whatever comes out that works, it takes 10, 12, even 20 years for it to bubble up and then get disseminated so that everybody understands what to do. So you can't go and just say, Bob, I think you're overutilizing. You can't do that because they say, well, prove it, right? And so they're doing what they think is right. Now, another circumstance in which people can overutilize health care or do unnecessary health care relates to a bad experience. Somebody has a really bad outcome. Primary care doctor misses a diagnosis on a child. Surgeon does something in the operating room that causes somebody to have a real bad outcome. Dies, something like that. And from that moment on, it changes your whole perspective. And you say, I will never let that happen again. And all of a sudden, you start changing your practice. So maybe you order an extra test before you take them to surgery. Maybe you put somebody in the ICU when they don't need to be in the ICU. They could be in a regular hospital bed. We could go on with that. And I'm sympathetic with it because I've done thousands of procedures, and there's about 8 of them I can't get over. Can't get over it. I'll wake up at night and I'll be thinking, God, what was I thinking? Happens in the car. That's inconvenient. But I never get over the fact that these patients and their families have trusted me and loved me and shown me grace in ways I would never have imagined. So I never would talk to a colleague that's had that kind of experience and say you're treating people inappropriately. I just wouldn't do it. So the third one is doctors have their thing. You know how you have your thing? Everybody's got this thing, right? And so docs get their thing. Surgeons particularly get this thing. So, I don't know how many millions of gallbladders we take out a year in the United States, but you would be shocked how many ways we can figure out to do it, right? And so everybody has a little instrument that they use, or they have a little technique that they use. It seems like it's more common in academia because academic people like to talk, and then you hold court on these poor people that can't get out of the operating room, like residents and students. And so you show them the same thing over and over, and the scrub nurse is going, God, he's going to tell that damn story again. So that happens not with infrequency. So there was a historic surgeon, Dr. Jim Hardy, was very important to me in my career. And he knew everybody and the day, and probably started half of the surgical societies in the United States. And he noted this kind of activity from younger surgeons. And so there'd be this big surgical conference going on, and there'd be this heated debate over something. And Dr. Hardy'd be sitting here, and there'd be this young guy over here, this young whippersnapper over here, and he raises his hands and he says, in my experience, and Dr. Hardy in the stage whisperer will go, he's seen it once. Then a guy over here says, invariably, and Dr. Hardy says, he's seen it twice. And there's a guy in the back that's seen it 3 times, and he stands up and says, time after time after time. I absolutely love Dr. Hardy. So that's the physician side. Now what about the culture side? Y'all's side. First of all, we don't do health care. We don't do health. What we do is rescue care. We do rescue care. And by God, we do it better than anybody else in the world does. But it's the child in the well. We will do everything we can to get the child out of the well. It's like the Chilean miners a few years ago, right? So think about this dynamic. So, we do liver transplants. And we do face transplants now. What is up with that, right? But so a liver transplant will cost, what, $750,000? So we can do a liver transplant, but we can't figure out how to take care of 100 Medicaid kids that are wrongly diagnosed with ADHD that are going to live with it for 20 years. And that's something we're actually actively working on. But that drives you crazy. Something's just not right about that. I'm not saying we're not needing to do liver transplants. I didn't say that. But it's something that we need to think about, okay? Now, this is a touchy one. Culturally, a lot of y'all like health care. Y'all like going to the doctor. You feel a little twinge somewhere, and instead of waiting 3 or 4 days, and taking an ibuprofen, you're going to call a doctor up. They're going to call something in for you. Happens all the time. There'll be primary care docs who will specifically say, well, yeah, if they come, I got to give them something, because if they leave without something, they get mad at me. A lot of us would rather take 2 pills than we would to eat right and exercise. I'm just saying. All right? But I think where we have a real challenge, and it's an expensive challenge, and it is an emotional challenge, and something that we do not do well at all, is end of life. End of life is a hot button, and we don't touch it. And I've got an experience from it from my own family. So my dad was a successful trial lawyer, had all the access to health care he needed and everything. So a few years ago, he was diagnosed with stage 4 lung cancer, had a big tumor in his chest, and then he had a metastasis in his brain. And the day he was diagnosed, he had a prognosis of about a year, okay? So he took some chemotherapy, a pill that was chemotherapy, and some radiation, and he was kind of doing okay, actually. And I need to mention, he was also, outside of his cancer, he was a train wreck. He had all kind of heart disease. He's the kind of guy that says, man, I don't have high blood pressure. He said, you're on 4 medicines for it. What do you mean you don't have high blood pressure? That's how he thought. But anyway, so he has this background cardiology problem, right? This heart problem. He'd been in the cath lab probably 5 or 6 times. So here he is on month 10 of what it's expected to be his life. And he has chest pain and shortness of breath. So his wife takes him to the emergency department, ironically where I worked. And his cardiologist, family friend, good guy, takes him to the cath lab. And I think they were trying to open up an artery to reduce his pain. And he codes. He codes in the cath lab. Intubation, I think he may have gotten some chest compressions. And by the time I get there, he's in the ICU. intubated on a ventilator with medicine to keep his heart pumping, and he's got 2 months to live. I mean, how did we miss that? That's exactly what you don't want to know. I mean, what you don't want to have happen. And we saw it from a mile away, and we couldn't even manage it. In the big picture here now, why is unnecessary care bad? So think about it this way. If somebody gives you something that can't help you, they give you something that can't help you, then it can only cause 2 things. Number one, it's going to cost you. And it ain't going to be 15 cents. Right? Number 2, it can cause a complication. Now that's going to be harmful, and it's also going to be expensive. So what we call that is quality waste. And quality waste is one of the main things that is driving our problems with healthcare. If you look at a normal hospital in the United States, 20%, 30%, maybe even up to 50% of all the clinical activity in the hospital is quality waste. Waste, waste, waste. And it can only cost and it can only hurt. So it's important for y'all to understand this dynamic between cost, quality, and unnecessary care. So here are your marching orders, all right? Number 1, you're in the doctor's office. They're telling you something you don't understand. Do not leave the office until you understand. That is your responsibility. Number 2, if you're in the doctor's office and they're telling you something you don't like or that you don't trust, you have got to go talk to another doctor. Number 3, if they want you to have some test or want to have some kind of procedure, you do not get to sit there and kind of stare at the wall. You have got to understand the risk and benefits. And if you are waiting till end of life to talk about end of life, you've waited too late. Thank you.